Thanks, Bruce. We'll introduce Steve, who is the Principal Legal Officer at the WHO in Geneva, and he focuses on WHO governance and international health law matters. He served on the WHO as a legal advisor during the negotiations of the PIP framework. And prior to that, he was the Deputy Legal Counsel at the United States Mission in the United Nations Organization. And prior to that, he was also with the State Department and worked on Capitol Hill. So he has a wealth of legal experience. Thanks, Steve.
Okay, thank you, Jackie. Thanks to the organizers for inviting me, and thanks to all the other panelists, but in particularly Bruce for a perfect segue, because you had said that one of the themes here is that time matters, and I'd say there are some sub-themes, and I'm going to drill down into what happened with the time during 2009, but some of the sub-themes are that global health equity matters, because if you got that right, you save time. Other things that matter are international law matters, because this was an IHR context to this. Contract law matters, because we're going to talk about liability and indemnification. Can you hear me? We're going to talk about liability and indemnification, and those are issues that sound like boring legal issues, but they matter a lot to countries, and they can slow things down or speed things up, maybe, if it's done right. And then finally, Bruce referred to this when he talked about the volcanic eruptions and the cold chain issue. The other area of law that matters is Murphy's Law matters, because something always comes up, and you got to deal with it. And there are often legal implications to that. There was something that Amanda in the previous panel said also about who we have to keep in mind when we're talking about, especially at the political level, but also at the legal level, and that's the ministers of health, the politicians themselves, because they are a key audience in all this. So you'll see that the first slide here, I think, Bruce, I need that, shows the Health Assembly, because this is where we meet at the Palais, at the Palace of the United Nations in Geneva. Seated in that room are generally 194 ministers of health, and they're the ones that put together the global norms. They're the ones that review the activities of the Secretariat, and they are the ones that, when it comes to responding and expressing needs during a pandemic, they're the ones that matter most immediately. So how do I turn this thing? Okay. So I said that global health equity matters and that the audience here is the ministers. What the touchstone for ministries of health is really the WHO Constitution, which sets out the definition of health, but also establishes this principle of equity, that it's the health of all peoples and the attainment of that as the fundamental issue and the fundamental objective of WHO. So this is really the larger overall context for this. WHO's functions here, of course, our mandate is principally in this issue, furnishing aid in emergencies, but it's the one above it that matters, two above it that matters, assist governments upon request in strengthening health services. That's what we do before the crisis, and how we do it, and that's working with all the stakeholders, the top one, coordinating, collaborate, and cooperate. Here's a little picture of the IHR, and Professor Fiddler spoke about this yesterday. These are just grouped some pluses and minuses, but as an example of what takes time from a legal perspective. The Emergency Committee had to be stood up in 2009. Now, we've gotten a lot more experience with the Emergency Committee. We've gotten better at that, but we had to learn some things. Originally, when we stood up the Emergency Committee, we didn't publish the names of who was on it. We thought that would protect him and give him more independence from outside pressure. We learned that it created a transparency problem, and we switched. So we're doing the Emergency Committee better. But there are things on the right-hand column that we need to work on. Financing for implementation. IHR core capacities are really brushing your teeth. You got to do it all the time. Same thing with an awareness of the regulations. All right, so to drill down into what took time in terms of WHO's side. You heard the national side, the qualification. WHO has its own, as you've heard, pre-qualification review. We had to do that. We had to run through the eligibility assessment of recipients. Principally, we were looking at, do they have a domestic capacity? Can they buy commercially? And if the answer to that was no and no, then they got prioritized, but that takes some time. DG then has to send a letter to the ministers. Literally, she sends a letter with attached terms and conditions. And it's like the terms and conditions that we all see when we download a document, except we generally don't read those. But ministries of health do read those. And it is very weighty and very heavy. And I'll show you an example of what's in those in a second and why that takes time, and also why it can be a problem for vulnerable countries in particular. Then the ministers of health have to respond. Then there has to be a signature of this. And this happens over and over. 95 countries were picked out in 2009. 94 of them said, yeah, we'd like some, please. Then they have to produce national deployment plans. This all has to happen very quickly. And in a crisis, when we were doing this for essentially the first time under the IHR, for the first time, it took time. So here's an example of how complicated it gets. This is the indemnity and liability and hold harmless clause. Now remember, we're working in multiple languages. We have 6 official languages. So we have to do this in multiple languages, and we have to go through this with each country. They want to understand this. That's not the issue of them understanding it. What's the issue is indemnification. It means making someone whole. It means paying them. And countries, particularly vulnerable countries, may not be able to do that. Even if they want to say, we won't sue you, they may not be able to say, and you know what, if you are sued, we'll pay your bills for you. And so that's a long reach. And so we got to think about it in that sense too. Then, what else is in all these terms and conditions? All of that stuff. And that's, again, multiple of 94 times going through that. But the big problem was not the legal problem. We could get this done relatively quickly. There was good uptake on this. The problem was the national deployment plans often didn't accommodate the speed with which we had to operate. So how can we make this better? 3 quick things. 1, we need clearer legalese. I recognize that sounds like an oxymoron to people, but it is possible to do. And we need to do it in all languages, maybe even all domestic languages, not just our officials. We need to, most importantly, pre-discuss, pre-agree, and pre-position all these terms and conditions. Now, PIP does that, and we are doing that under the Pandemic Influenza Preparedness Framework. So that will help enormously. And finally, we need to consider another possibility, which is especially for vulnerable countries. Do we need a global insurance mechanism for adverse events to help them when something happens and to help them say, okay, I got it, we can take this as soon as you can give it to us. So these are some ideas, and I think I'm under 7 minutes. Okay.
Okay.